Thank you, Manoj Mathur, and at the outset, I would like to thank Telangana Ophthalmic Society and All India Ophthalmological Society for providing this opportunity for us to share the knowledge with you. And today I will be sharing my experience in vitreoretinal interface disorders. What is the vitreoretinal interface? It is the most posterior part of the posterior hyaloid layer and internal limiting membrane. The interface is always very thin. See, 100 to 300 microns, and the lot of disorders can happen in this. And I listed all the disorders here, but I will discuss some of them because it is from PVD to epiretinal membrane to macular hole, pseudo hole, and full thickness macular hole. So the first of it is, though many people think that posterior vitreous detachment is very innocuous, actually it is most dangerous. If you see the age, even at 50, 25 also, there can be posterior vitreous detachment which can result in retinal detachment. Though below 50 it is 10%, and at 70 it is almost 50% of the people can have PVD. This can result in rhegmatogenous retinal detachment, and a close follow-up up to 2 months is very essential. This patient is a 60-year-old female, came with vitreous hemorrhage, and I called her. Luckily, after a week, you observe there is a temporal retinal detachment with trachma. So what I did is I given some gas and did a cryo. After 2 weeks, that has healed. There is another break, and the detachment is extended. So here the vitreous detachment is completely not relieved. So we had to do vitrectomy and completely cover all the breaks to give a good result. Luckily, she never lost the 6/6 central vision all through follow-up. And if you go for vitreomacular adhesion or traction, which Malika was referring, we should see what type of traction we are dealing with and what is the stretch it is having. And these tractions should be relieved. And most of these tractions should be relieved by surgical interventions. Like this patient is having vitreomacular traction, and we have done pars plana vitrectomy, ILM peeling, and fluid gas exchange. ILM peeling is very essential here, but how we do it is also essential. Means you should go around the macular center so that there will not be any creation of macular hole in these patients, and a good result has come. See, 25-40 vision in these patients is very good. And another disease pattern of vitreoretinal interface disorders is epiretinal membrane, which can cause decrease in the vision. And the type of epiretinal membranes decide how successful we will be and how to plan during your surgery. So the plane on OCT is very essential here. Here this membrane is not very tightly adherent to the retina, and it can be easily removed. There are certain membranes which can happen, not in this case, but the next case. The here also it came out nicely, and the foveal contour is retained, and vision also comes very nicely. This case, there is adhesion, and there is the tentacles are going into the retina. Here the dissection can be very tricky, and you should be very careful while dissecting the epiretinal membrane in these cases, because certain times retinal tears can happen, and it may lead to retinal detachment while you are removing the retinal detachment. So I'm lucky that it came out very nicely, and then the result will also be good. The last one is the macular hole, but clinically you need to identify lamellar macular hole from a full thickness macular hole. The lamellar macular holes again can be inner lamellar macular hole and outer lamellar macular hole. Both lamellar macular holes do not require any intervention. This is important. Clinically, you identify lamellar macular hole, easily you can follow without losing further vision of that patient, and close follow-up is required. However, once full thickness macular hole develops, in 95% of the times, we can close the hole and we can improve the visual acuity. So that is the importance in identifying what type of hole we are really encountering in the clinic. So this patient, we intervened and you can see the outcome. Visual outcome is 20/20, which you can't anticipate with otherwise. Only follow-up do not give this. And again, another patient of macular hole and 20/80 vision, good outcome. The contour is good, the outer layers are good, and neurosensory, retinal neurosensory, that is rods and cones layers, is also getting improved. In albinotic funduses, you see the contrast is very poor. So here, mainly the chromovitrectomy and staining is important. Of course, we nowadays do staining in all the cases, but here it is much more important so that the ILM peeling can be very, very facilitated and the outcomes can be good. So even in this albinotic fundus, we could achieve a very good surgical outcome. With this, I would like to conclude that vitreoretinal interface abnormalities results can present in different variety of clinical picture, and this requires lot of interventions. Common intervention is vitrectomy, ILM peeling and tamponade agent. However, if there are additional changes that need to be applied case to case basis, and most of these disorders results in a good visual acuity. That is more important. So we should not neglect clinically and intervene and give a good visual outcome. Thank you for this opportunity.
Thank you, Dr.
And I
Ajit
given
Babu.
you 3 minutes.
That is a lovely talk, very nice images. While Dr. Rashmin comes on, I'll just ask you one question. Recently, the Optos company has launched one OCT, wide-angle fundus camera, which also does peripheral OCT at any point, almost till the equator. And I saw a very interesting presentation in which many of the cases of white without pressure, etc., essentially were all addition of the vitreous to the retina.
Yeah, it's
so
now. Yeah.
Is there a case that earlier at before doing LASIK they used to do 360 degrees barrage? So cases in which if we have these technologies where we are seeing addition in the peripheral retina, would it still make sense to kind of do a 360 degrees barrage before doing procedure like a LASIK or cataract surgery?
I'm a critic of doing excess barrages.
Okay.
I'm very, very sparing and conservative in doing lasers.
Right.
Because everyone thinks that by barraging the laser, you are protecting. You are not protecting. You are creating a temporary strong adhesion in that area.
Which
but
again
what
can
will happen to the edge of that strong area? Again, there is a weak and strong area.
Yeah.
So that really, it gives you a false sense of protection, where you will say patient that you be yourself, and you are putting him into more danger rather than a protection.
Thank you.
Yeah, PVR can get enhanced actually with laser.
Yeah.
And the vitreous, the liquefaction will also get enhanced. So you are enhancing the disease process also. So I am very, very conservative.
Thank you, sir.